speaker will be Dr. Mohamed Hassanein from UK. He will talk about characteristics of people with diabetes mellitus and cardiovascular disease.
Thank you very much for the chairpersons and for Dr. Ines, and thank you all for staying till the important part of the program. Usually it's the best part is the last part. So encourage you all to stay until the end. My topic today is about the characteristics of people with type 2 diabetes or diabetes in general and cardiovascular disease. We know that in general, cardiovascular disease is one of the main causes of morbidity and mortality in people with diabetes. And the question is, do people with diabetes have different characteristics, or why do they develop these problems? In the West, when you look into data of those who have cardiac problems or cardiovascular problems, you will realize that about a third of them have glycemic abnormalities, whether frank diabetes or pre-diabetes state. The question is, what is the situation in our communities? I'm delighted to be part of this research coming from my home city of Alexandria, and this was published not long ago, earlier last year, this year actually, 2019. Professor Samir Haimi was the first author with a group from Alexandria University as well as from one of the other academic centers in Alexandria, including myself in collaboration. And I want to be here to focus and look into those who develop peripheral arterial disease as PAD, of those who with the total. What was the difference in HbA1c in those who have the answer of yes versus no? You will see that those who have peripheral arterial disease tend to, as one of the markers, to have more hyperglycemia. And the same was with chronic kidney disease, with neuropathy, and with retinopathy. So clearly, poor glycemic control is something we need to try and address. Here in this particular part of the study, they looked into the prevalence of these problems. And here, as a total, it is sad to see that 32% of the sample of 500 persons from Alexandria with diabetes, 32% have peripheral arterial disease, with clinical examination that was done on every single individual. If you would like to look into those who have been recently diagnosed during this research, because a quarter of the population was identified as a person with diabetes when the screening program happened, versus those who have already diabetes that's been well established. So 183 of them had diabetes, was diagnosed during the screening for this program. And at the time of diagnosis, they just knew they have diabetes. As you can see here, peripheral arterial disease is, as you can see here, 45% of them. Chronic kidney disease in 46%. So there is a lot of undiagnosed problems in many of our communities in Middle East in general. This is data from Abu Dhabi. I currently work in UAE, and this is data from Abu Dhabi. This is much more comprehensive because this is data for 50,000 persons who, all Emiratis who joined the insurance program. So everyone had an insurance program, fully comprehensive, when they were doing the survey for joining the insurance. Here is the information. So the mean age of the population is 36 years. Hypertension is there in 23%. So roughly a quarter of the population of Wuqaya, a straightforward insurance program, has people with hypertension. Dyslipidemia was 44%. Obesity and overweight together is 75%. So clearly, our communities, whether in Egypt or whether in UAE, there is loads of cardiovascular risk factors that is present there. I have highlighted for you here, have covered all the other parameters and left hypertension and diabetes. And you will see that a person with hypertension is almost identical to a person with diabetes. Obesity, whether an overweight, is very high. Dyslipidemia is high. Smoking is not the most concern, it's 8 to 10%, but it's the other risk factors. If they have diabetes, 60% of them have hypertension, and if they have hypertension, 67% of them, 68%, will have either diabetes or pre-diabetes. So clearly, the problem of both factors is quite in abundance. Here is another set of data. Here are people who were admitted to the coronary care units with a diagnosis of coronary heart disease from the Middle East and from the Gulf countries. And as you can see, Middle East versus the overall, because in the same study, this was an international study, and they were trying to compare the data of our cohort, the Middle East cohort, versus the Western or the international. So you see, light blue is, as you can see here, is Western Europe, the darker blue. The greenish blue is the Middle East, and you can see clearly that the age at the time of admission with an acute coronary syndrome is much younger, it's about 15 years younger in a person who's coming from our region. So clearly there is something that needs to be done. Obviously, when you start to think of why this is happening, here is the methodology of the study. They tried to look into matching people, and there was a number of factors that were much higher in Middle East compared to the Europeans. Smoking is one of them. Of course, smoking in the past used to just be cigarettes, and used to be something that you do without maybe socially acceptable. But now shisha is very acceptable. Ladies, men, young girls, young men, it's becoming a social thing. In the past, this was something for maybe a specific part of the society which wasn't associated with being cool. But now it's cool if we go to have shisha together. It's enjoyable. Alhamdulillah, I have stopped it 2 years ago. But one of the other problems, as you can see here, is abdominal obesity. Of course, the ApoB and ApoA1 are there, so problems with dyslipidemia. But the bottom line is, we really need to start thinking into what are the things we can easily change in our lifestyle, in our behavior, and in our community in general. This is similar data to what I've shown you before. This is the Gulf race study, so this is purely the data coming from the Gulf, and still more or less the same. Prevalence and impact of cardiovascular risk factors on patients presenting with acute coronary syndrome. Diabetes was 40%, hypertension 49%. So we're really talking about these cardiovascular risk factors are in abundance when it comes to the person admitted with this. In my hospital, a group from our endocrine department, along with some of the cardiologists, and we teamed together in Dubai Hospital in Dubai, and we decided to look into prospectively into what is the difference between a person going to the hospital to the cardiac department with diabetes versus the person without diabetes. We looked into data of 328 persons, and at 328 consecutive admissions to the cardiac ward, 46% of them had diabetes. So nearly 1 in 2. Every second admission to the cardiac unit with ischemic heart or with heart failure is a person with diabetes. When you look into those who had previous cardiovascular disease, not newly diagnosed, they have history of cardiovascular disease, the percentage of people with diabetes jumped up to 2/3. 66% of them have diabetes. And we started to look into gender. The population in UAE is mostly males. There's lots of employees who are males. But nevertheless, it looks like whether this is for local or for non-local, there's a huge amount of male majority in people with cardiovascular problems. So it looks like ladies can get away with it. They break our heart emotionally and physically as well. So we need to be careful, men here in the room. But when you look into it a bit more serious, when you look into why do males have higher rates of cardiovascular disease in comparison to females, it's not just about there is more males in the population. So in this comparison, I looked into the Ohio data because it's a big data set of 55,000. And as you can see, that the difference is largely in the factors that I have put here for you in red, mostly related to central obesity and to smoking. So it is no one, and to stress as well. So hypertension, central obesity, and smoking were much higher prevalence in men compared to women. So no wonder we can end up with a serious cardiovascular problems. But another very important point which became very topical nowadays is about heart failure. Heart failure specifically in people with diabetes. And in our data, in our study, we looked into the cause of admission. And we were terribly surprised to see that the rate of heart failure as a cause of admission in people with diabetes was 36%. In people without diabetes, it is only 16%. And this is in people with no previous history of cardiovascular disease. So this is someone who never have a cardiac problem and gets admitted to the cardiac ward. What is the diagnosis in 36% of them? It's heart failure if they have diabetes, and it's only heart failure in 16% if they don't have diabetes. Of course, with a previous history of cardiovascular disease, the cause of heart failure for the admission is much higher, and it's then equal between the two groups of people. We know that people with diabetes from many other studies is a risk of developing heart failure. As you can see here, diabetes as well as renal impairment were two of the very common causes of developing heart failure. When we looked into the difference of a person with diabetes versus a person without diabetes, there was plenty of differences, including one which is really important from a financial point of view or from a service point of view. Because if you're the doctor in the hospital and you look after the diabetes department, number one, you will be called for almost 1 in 2 of the patients in the cardiac unit because they do have diabetes. The second problem is the length of stay. Clearly you can see here, the length of stay for a person admitted with a cardiac problem who's non-diabetic is about 5 days. If they have diabetes, it is 7.1 days. So that's obviously is an extra cost, an extra burden on the departments or on the finances of the individual themselves. There was no major difference in blood pressure. As you can see here, orange and blue almost overlap. So there is no major difference in them in blood pressure, and there is no major difference in lipids profile. LDL is also very much in overlap between the two. But I want to raise your attention to 3 important factors that in huge abundance in our community, which can lead to serious cardiovascular death. One is poor blood pressure treatment. Second is salt, and the third is the type of fat that we see the adverts in the TV programs all the time, salmon, the manufactured type of fat. These 3 were checked in a study, and the study title was 3 interventions that globally can save 94 million deaths, 94 million lives. And in this particular study, which was published in Circulation this year, not long ago, and it looked into so many data from so many countries, and they wanted to address 3 of the important points. What if we make hypertension treatment available to far much more number of people because it's easy and cheap and not expensive? And their target was to reach 70% coverage of those with hypertension. The second was salt reduction, and the third was avoidance of the wrong type of fat. Salt in particularly, when you look into our communities, Middle East, Egypt, Lebanon, Turkey, Gulf, We love our salty foods. Mkhalil, nuts. You need to just think of so many cheese, salted cheese, all of these types of food. I remember my wife used to be angry with me because I used to add salt before tasting food. And she said to me, taste it first, and then decide whether you need to add salt or not. So I stopped, I listened to my wife, and I stopped adding extra salt. But it's an acquired taste. If someone gets acquired to high level of salt, they will not accept low salt, unless gradually, and vice versa. So all of these important points, I say to many of my patients, many family members I have, you have high blood pressure, you have diabetes. Why do you have all of this amount of salty food? Mkhalil, salty cheese, and so on, let alone ringer, seed, sugar, all of these lovely food, but is high in content of salt. Because the data that they have shown and published in circulation of this year, salt reduction was equivalent to hypertension treatment. In reduction of mortality and life saved, the reduction in salt, as you can see on the third bar, was higher than increasing the availability of antihypertensive. Of course, if you do both, then the outcome, if you do the three, this is the amount of over 40 million lives in women and equal 50 million lives in men, added together would be 94 million lives that could be saved with modification of the lifestyle. What were the conditions that were saved? You can see them here on the chart. The vast majority of them were cardiovascular-related medical conditions. And this is all very simple. Unfortunately, the type of fat that we eat in the Middle East and gets advertised is the worst type of fat. We're far much better to cook with butter or with pure oil, rather than, sorry, I would say in Arabic, salmon, because it's hydrogenated type of fat that is really very high risk. And if you were to talk to colleagues in the States, no more you can buy or this is be sold in any type of biscuits or cakes or in any restaurants because of its impact on cardiovascular risks. Of course, for manufactured food, biscuits, cakes, all the pizzas, all the easy type of food, it is that type of food, fat because it's cheap and it's easy to do. So, ladies and gentlemen, dear audience, in conclusion, prevalence of diabetes in people admitted to the cardiac units is roughly 50%. To be precise, in our study, it was 46%. There is far much more men than women, and it's mostly related to men's habits of smoking, partially the central obesity, and partially the higher prevalence of hypertension, which could be stress-related. Diabetics have a higher prevalence of previous cardiovascular disease, and heart failure is much more in people with diabetes compared to people without diabetes. So it's important that we screen and ask our patients for symptoms of heart failure and treat it if obviously it's there. They end up staying in hospital longer, which obviously is a burden on the health system as well as a burden on the individual if they are paying themselves. And certainly action is required for this. Conventional risk factors are really quite important. We really need to try to, when I see a person with diabetes, I say to them, never stop your statin. Never stop your blood pressure treatments. You might dislike one of them or whatever, but never stop it unless there is a serious medical condition. We obviously need to work together and do it as a multi-systematic approach. And of course, we need to look into systems that can make the availability of simple, less expensive, lipid-lowering drugs, blood pressure treatment, and of course, the treatment of glycemia need to be far much better in approach. I lastly and finally advise you, if you all have any research that you wish to publish, I'm a co-editor in the newest diabetes journal in the Middle East, from Dubai Diabetes and Endocrinology. Please log in. The good news is free to publish. It would not cost any pence to publish there, and it's a fast process. And I would also like to invite you to the 8th Diabetes and Ramadan Conference in Dubai, where hopefully there will be more and more research. Last year, we had 16 new studies presented. And finally, my lovely old city of Alexandria. Thank you.